Hello everyone, welcome to this discussion where we are going to take up one very important topic relevant for your super specialty exams in pediatrics. Before I start with the topic, I want to emphasize why I have chosen this topic. It's a very short topic, it's a very brief topic, and there is a good possibility that you are already well versed with it. If you already know the topic, it will be a good revision for you. You can save it. In case you are not well versed with the topic, you can add it to your notes, right? So the topic importance is this topic has been asked directly or indirectly in both NEET Super Specialty as well as INI Super Specialty exams in the past. So it's relevant for both the exams. Secondly, the cases related to this topic, even if you don't see the exact same case, discussion part in board rounds will eventually go towards aspects of this particular topic which we are going to take up. Thirdly, if you get a neurology case or your examiner in the final viva in DNB or in MD, he or she is a neurologist, you are going to get questions being asked from here. And lastly, departmental assessment, uh, twice a year, you will find sometimes case scenarios, some stations, this topic being asked there. So without wasting any time, let us have a look at the topic. Why am I not talking about the topic? Because I want you to first have a look at the MCQ. So the MCQ goes something like this. And trust me, you may find similar scenario in real life as well. So look at the question now. There is an 8-month-old child who presented with complaints of recurrent attacks of seizures. So there is a 8-month-old child. There is an infant presenting with recurrent seizures. The seizures started at 6 months of age. So onset is in infancy. They were mostly associated with high-grade fever. So fever with seizure could be febrile seizure, could be fever triggered seizures, right? The seizures were unilateral clonic type. This is a very important point. And they occurred in clusters requiring hospitalization. And you saw the medical records and found that in one episode in the past, before the child came to you, there was a worsening on starting the phenytoin in the patient. Which among the following is not true? So they are asking for options. It involves SCN1A gene mutation. Option number B, developmental delay occurs in most patients. Option number C, clobazam and valproate can also worsen the patient along with phenytoin. And option number D, atypical absence seizures can also occur. So what they're asking is the incorrect statement here. So they're asking which is not true. First of all, before we go to the individual options, we need to make the diagnosis. So what are the clues in the question? So what are the clues that you can see in the question? First of all, this is a patient who's having onset in infancy, onset of seizures in infancy. This is the first clue, right? So onset of seizures is happening in infancy. This is the first clue. The second clue that you can see is these are focal clonic seizures. So focal clonic seizures are happening, and these focal clonic seizures are occurring in clusters. Cluster means in a very short span of time, there will be grouping of seizures, and in between those clusters, there may be a relatively normal period, a seizure-free interval may be there. Thirdly, most of them are associated with high-grade fever. So they are associated with fever. They are associated with fever. Obviously, these are severe seizures. That is why the child is requiring hospitalization. And fourthly, there is a worsening on starting phenytoin. See, many seizures tend to worsen on starting ethosuximide. A few myoclonic seizures tend to worsen when you start carbamazepine or oxcarbazepine. But this particular seizure, you would notice it is worsening on phenytoin because of all the spectrum of features and the association with fever. The likely diagnosis which is coming to the mind, it is Dravet syndrome. So the patient is likely suffering from Dravet syndrome. Only once you know that it is likely Dravet syndrome, then you would look at the other points and see which of the following statement is true and which of the following statement is false. Remember, whenever you get a case scenario in super specialty exam, first thing is to look at the clinical picture and make the diagnosis in your mind, and correspondingly, you would be looking at the options, right? So let us start with the discussion. There are epilepsy syndromes which are associated with, which start as febrile seizure. Nelson very clearly says that almost any childhood epilepsy can have association, or they can initially begin as febrile seizures. But there are three important epilepsy syndromes which initially start as febrile seizure and then tend to convert into non-febrile or the typical epileptic syndromes, right? So what are the three epilepsy syndromes which start as febrile seizure? The first one among them is the one which you might have read already, that is GEFS plus. What is GEFS plus? It's a type of febrile seizure associated epilepsy. The full form stands for generalized epilepsy. Generalized epilepsy with febrile seizure plus. I hope you know the funda that if febrile seizures continue beyond 5 to 6 years of age, we call it as febrile seizure plus. And if there is a genetic component involved in it, where the seizures are more frequent and generalized epilepsies occur, then we call it as GEFS plus. It's a separate topic, so we'll not be going into details in this brief video right now, right? So GEFS plus. The second epilepsy syndrome which can present like this is temporal lobe epilepsy. So we have the temporal lobe epilepsy, particularly if the temporal lobe epilepsy is secondary to mesial temporal sclerosis. So these patients can also initially have onset of seizures as febrile seizure, and later on the true clinical picture comes through. And the third one is the syndrome we are talking about, that is Dravet syndrome. And Nelson very clearly says, similar thing is mentioned in Swayman also, that among these three, the most severe among them is likely to be Dravet syndrome. So most severe among them is which one? It is Dravet syndrome. You can get a MCQ on this in exam also. All of the following epilepsy syndromes commonly start as febrile seizure, except now theoretically any febrile seizure can present, any epileptic syndrome can start as febrile seizure, but in these patients Nelson specifically talks about these three, and the odd one out will be your answer in the question, right? So let us talk briefly about Dravet syndrome. I'll not be taking it in the usual way because it is a revision topic that you are watching. So Dravet syndrome, what are the MCQ relevant points which can be asked to you in the MCQs and sometimes in the Viva also? So they can ask you what is the other name or alternative name of Dravet syndrome. Alternative name of Dravet syndrome, it is also called as SMEI. What is SMEI? It stands for severe myoclonic epilepsy of infancy. So severe myoclonic epilepsy of infancy is the alternative name of Dravet syndrome. So sometimes they will put Dravet, sometimes they will say SME1, SMEI. Don't get confused if either of the two is being interchangeably used. Second, what is the gene involved? It is a genetic epilepsy, right? So just understand that about 80% patients, you can find a gene. The gene is identified. And if they say which is the most common gene which is identified, the most common gene is SCN1A gene. And this SCN1A gene, this is not I, this is 1. So SCN1A gene is the most common gene involved, and I'm putting a Q on top of it because this is the past NEET Super Specialty MCQ. So most common gene associated with this is SCN1A gene. Can there be other genes involved? Yes. Other genes which are sometimes involved, they include SCN1B. It can also occur due to SCN2A gene, and there is also a GABRG2 gene. So these are the other genes which have been implicated. In fact, when you are evaluating, when you are doing a genetic analysis, you need to check for all the 4 genes. The entire gene panel needs to be checked for. But if they ask as a one-liner, most common gene, it is SCN1A gene. But Nelson also clearly says that about 10 to 20% patients, no gene is identified. Gene should be there, it would be there, but we cannot identify the gene, right? Now, what is the type of inheritance? Although it is a genetic epilepsy, but you need to understand that most of the patients, they are sporadic. So if they ask you what is the type of inheritance, it is not inherited, it is a de novo mutation. So sporadic inheritance can sometimes occur. So sporadic or de novo, depending upon how the MCQ has been framed, right? So mostly it is a sporadic condition, and rare patients, rarely, the patients can show autosomal dominant inheritance. Now, next thing, Dravet syndrome, what is the morphology of the seizures? How do the seizures begin? Initially, the key thing to understand is they will always have onset in infancy. So onset will always occur in the first year of life, and initially most of these patients, they will be having febrile seizures. What are febrile seizures? You know what are febrile seizures. I'm not going to go into detail. So they will start as febrile seizure. Later on, you will find that they will be associated with lower grades of fever also, till you reach a point of time in the natural history where fever does not trigger the seizures at all. So they begin as febrile seizure, but gradually as the age increases, the seizure recurrence keeps happening, and gradually the association with fever tends to come down. So initially they will start as febrile seizure. But how will you distinguish? How would you think that this is not febrile seizure? I hope you remember that most of the febrile seizures are simple febrile seizure, which are generalized epilepsies, and they are self-limited in nature. These patients, you will have usually one side of the body, focal clonic type of seizures will be there. These focal clonic seizures will be abnormally prolonged. Some of them can get converted into focal febrile status epilepticus also if the duration exceeds more than 30 minutes. They will be happening in clusters. So a lot of frequent seizures will occur in a very short span of time, and they will be severe. Most of them will require hospitalization and administration of benzodiazepines. So focal clonic prolonged clusters of severe seizures will be seen, often triggered initially by fever, so mistaken for febrile seizure, but as age increases, the degree of fever association with the seizure will come down. Now, what are the associations? You will find that as the age increases, other types of seizures can also be seen. So you can have patients having, ye to rahega, this will always be there, but the patient can also have atypical absence seizure. The patient can also have myoclonic seizures. Myoclonic seizures. Patient can also have occasional, some bad luck patient can have status epilepticus. So I'm writing SE. And last but not the least, by second year of age, you will have developmental delay. So delayed milestones will also appear in the patient. So these are the associations associated with Dravet syndrome. Now, what are the effective drugs and what are the worsening drugs that you need to know? Now, there is no such thing as drug of choice, but generally it is found that the first line agent in these patients, the first line agents include valproate as well as clobazam. So valproate as well as clobazam. For acute epilepsy, acute episode, we usually prefer clobazam. Sometimes you can use benzodiazepines, other benzodiazepines also. But Nelson as well as most of the textbooks are very clear that valproate is actually the more effective drug. Although Nelson mentions clobazam initially, right? But generally, valproate and clobazam, both of them are considered first line drugs. Another first line drug which is effective in these patients, which has been recently FDA approved, are the cannabidiols. Cannabidiols. But cannabidiol is approved for use in the age group of equal to or more than 2 years. We usually start in a dose of 10 mg per kg per day in two divided doses, 5 mg per kg morning, 5 mg per kg evening, and gradually you can increase up to therapeutic doses of 20 mg per kg per day. So 10 mg per kg morning, 10 mg per kg evening, but give it above 2 years of age. And in case patient is not responding in refractory seizures, you can always go in for ketogenic diet. So ketogenic diet has also been found to be effective in many of these patients. But then the question arises, what are the worsening drugs? What are the drugs which worsen Dravet syndrome? One of the drug we have already seen, it is worsened by phenytoin. It is also worsened by carbamazepine. It is also worsened by oxcarbazepine. It is also sometimes worsened by, particularly if it is a status epilepticus patient and you give barbiturates, either barbiturate as a mini bolus, phenobarbital, or you try to give thiopentone or barbiturate coma in the patient. These patients are going to worsen. They have a poor neurological outcome. So barbiturates can also worsen. So these are the four category of drugs which can worsen the patient, right? What about stiripentol? Stiripentol has problems of availability, and still many neurologists, they do use them. But stiripentol, there are problems related to pharmacokinetics of the drug. Availability is an issue, cost is also an issue. And stiripentol, when you are co-administering with other drugs, it has a tendency to affect the concentration of other drugs like clobazam, valproate, and other drugs affect its metabolism as well. So you can remember that another reserve drug, very effective drug, but clinically not always useful. It is stiripentol, right? So this is another drug which is effective. So these are the drugs which are effective on this side, and these are the drugs which are not effective and they worsen the patient, right? So you can very well imagine MCQs to be asked from this topic. It's a storehouse of MCQ, very small topic, but multiple ways questions can be created out of this, and it does happen, right? So, do you know one thing? Nelson talks about it, and there have been some articles on this as well. So, there is a entity you might have heard called as vaccine encephalopathy. A child got a DPT vaccine. There was prolonged cry, hyporesponsive episode, and many of them due seizures. And progressively, there was developmental delay. We don't see them that often, but sometimes vaccine encephalopathy does happen, and mostly it is the pertussis bechara who's put it as the culprit in most cases. Pertussis may be there, but there is a school of thought and evidence is accumulating that many of the vaccine encephalopathies are actually not true vaccine encephalopathies. They are Dravet syndrome patients who are unmasked. When you give them DPT or pentavalent, the whole cell vaccine, fever comes, and fever triggers seizures, and the onset of developmental delay after that, neurological problems after that, is a sequela of the genetic mutation, right? So what do you need to remember about this? That many cases of vaccine encephalopathy, which were previously labeled as vaccine encephalopathy, are now known, they are now considered to be SCN1A gene mutations, that is Dravet syndrome, which is triggered by fever caused by vaccines. That doesn't mean that vaccine encephalopathy is not a term. It is a term. But the big number, the big chunk that we tend to see of vaccine encephalopathy, among that chunk, actually the true chunk of true vaccine encephalopathy, although it cannot be known, but a vast majority of them are likely gene mutations associated with Dravet syndrome, right? So any vaccine encephalopathy patient, now IAP guidelines very clearly say you should get a mutation testing done for SCN1A and the related genes. This is something very important. It's of public health importance in a way. It's not been recognized and it is not receiving so much of attention. And when you're doing residency, you have too many things to attend to. But keep this thing in your mind, particularly if you are working in a pediatric neurology clinic. There is a point I want to emphasize here. IAP 2022 standard treatment guidelines, you can Google it, it is clearly available. They have a brief review of febrile seizures given. Look at the table which they have given on the second last page of those guidelines if you want to read in details. That is why I'm telling you. The guidelines very clearly say that when to do genetic testing for Dravet syndrome in a febrile seizure child. First of all, in case there is recurrent febrile status epilepticus, right? Second, if there is onset of prolonged hemiconvulsive one-sided seizure below 1 year of age, so onset below infancy. Thirdly, any patient with vaccine-associated encephalopathy, you have to do genetic testing for Dravet syndrome. And I told you all the 4 genes have to be checked for. And fourthly, if there is a clinical picture pointing towards GEFS plus, then also you need to do genetic testing. So you should be asking me, sir, GEFS plus, why are we doing genetic testing for Dravet syndrome? A reason is very clear. GEFS plus also has mutations in SCN1A. But the difference is that Dravet syndrome patients tend to have a loss of function mutations. Whereas GEFS plus mutations, the function of the protein is altered, but there is less loss of function. And that is why Dravet syndrome is a more severe phenotype of the similar gene mutation in SCN1A. You understood? So this can be a MCQ, this can be a Viva point, and this is something to remember about the huge topic of febrile seizures. In the detailed video on Super Specialty app, we have discussed febrile seizure, but Dravet syndrome is one thing which commands its own rip-off sequel small web series. If it is a Marvel Cinematic Universe, then Dravet syndrome does deserve a few episodes of its own TV series as well, because it is frequently asked in the exam. Let's go back to the question that we had started. So this was the question. So what was the diagnosis that we had made? We had made the diagnosis of, yes, Dravet syndrome, right? Now look at the options one by one. What is the question asking? Not true. All those people who have given the exams, all of you are pediatricians. But one thing we still make the mistake in paper is you forget to look at all except, not true. All of the following are true except, these kind of things. So this question is asking not true. So Dravet syndrome, option number A, involves SCN1A gene mutation. It is a true statement. Developmental delay occurs in most patients. It is a true statement. Although it occurs after 1 year, but it occurs in most patients. Clobazam and valproate can also worsen. They do not worsen. They are the first line agents in these patients. So this is a false statement. And atypical absence seizures can also occur. It is a true statement. Once you know the topic, it becomes a very easy thing. And the answer here, the correct answer here in this question is option number C, right? So Dravet syndrome, read from Nelson. If you have already read, or if you don't have time for Nelson, make a screenshot, make a small sticky note, add it to a place, and add these points which we discussed here, and save this video for later revision also. I hope you benefit from it. Very soon I'll be back with similar high yielding topics beneficial for all of us. Thank you so much.